Good. The theme of this panel is high quality interoperable health data for care and research, but you have already witnessed how we moved from clinical research more and more to healthcare, and now we are fully in the healthcare domain. And I would like to introduce very briefly my panelists today. Michel Tonnet, representative of the French Ministry of Health, neuropharmacologist, applied mathematics, medical informatics, political sciences, public law, and several other educational background keywords. And Jeremy Taub, who will be also representing the ministry perspective today, Director of Business Architecture for the Health and Social Care Information Center in England. Very interesting. And social care, this is an important element to pay attention to, with many previous jobs also for the National Program for IT in England. Then okay, I changed a little bit the order, that's fine too, but then I will continue with the clinical perspective. Robert van der Stichele, to be short, Bob, a practicing family physician in Ghent, and I'm really proud to have a really practicing physician here among all the medical informatics representatives, and I can't avoid telling you that I already witnessed his expertise in real life and saving life of people. So Bob is also teaching professor in the Department of Pharmacology at the University of Ghent. Then the patient perspective, Petra, I don't need to present you because we already listened to your very nice talk today. And Christoph Ruprecht, head of Health Policy and Health Economics Department within one of the largest insurance companies in Germany, AOK, but also visiting lecturer at several institutions, and also very important, manager of several innovative healthcare services of telemedicine within the AOK. Good. To start with, we will be talking today a lot about interoperability, but I'm very grateful to Petra, who maybe solved one of my problems today, to find a new definition and a more sexy word for interoperability, to talk about ignition. I would like to ask you, all of you first, why is interoperability important? Still important, and maybe still more important. Michelle?
Thank you, Veli. I do not want to redo or to say again what the other one have very nicely presented this morning. Nevertheless, just to be obvious, if I may, the first thing that we need with interoperability is to be able to understand each other. We are here because we share more or less with different levels the same language. And so if we understand each other, it's the first step in order for us to exchange and to connect. And so the next step is team building. And what for? It's obviously for coordination. It's to be able to have some continuity in the team building decision, action, and initiative that we would like to take. And because we are here on the health purpose, it's also for continuity of care. You all know that it's the consequences of that, if we manage to make it happen correctly, is to try at least, maybe not to succeed yet, to reduce some kind of risk of non-quality, risk of duplication, to diminish the effort we have to do together, and maybe to be able to have less inaccurate information, and the V's in this is produce one, use many, as we have heard this morning. But it's lead to the possibility to have this data available for patients everywhere. And Thursday spoke about mobile tools, but also mobile person. But for that to be useful, we need to be able to reuse the data if we could correlate this data. And it's very important because sometimes, and there is some people really aware in this room, we have to archive this data for later reuse because we don't know yet if it is useful, it could be useful, and for what in the next future. So maybe my last point on that will be that in this case we need to be able to have some guidance, and for that we need to have metadata, not only data, but metadata. And because we do not always know what data and which data will we reuse for which purpose, we need also to be very careful with the condition and the metadata condition access as well, and not only the data, in order to have trust and to be able to have some scalability, and finally to have a trustworthy ecosystem.
No? It is better, is it? Right, okay. Certainly in an era where we're seeing rises in patients with chronic conditions, where we're looking to see to what extent can we help patients to live at home. We're looking about the ability, therefore, to bring multidisciplinary teams working together in support of patients. This whole issue about having a shared basis of information, shared records and so on becomes even more important than it has been before. And it sounds like I'm washing under the desk. I assure you I'm not, or if I am, I'm not doing it with my hands. In her presentation, Petra used a series of words beginning with E, and I was half thinking of matching that, but actually Michelle's already started with a number of words beginning with C, in terms of coordination, of consistency, and certainly if we're thinking then about being able to reuse data, comparability of data, all of those are features that are important in terms of interoperability, not only for the direct care of patients, but how we can then usefully use the data afterwards.
Bob, would you like to continue, and I hope the mic is working?
Yeah. Well, I try to pick from a perspective from the physician the two elements that are important, why semantic capability is important. We live in a healthcare system that is divided in a hospital care and in primary care. It's vital that these two settings cooperate, are able to communicate, and are able to exchange the data in their systems, especially when it comes to chronic multimorbidity. And let's say that primary care is the weak factor in this. It's unable to finance itself, it's less proactive, but very important to handle that multimorbidity. And so I think we must be careful that there are not two speeds of development in these issues. The ability to record and to communicate our information is essential between the two settings, and therefore semantic capability is essential. And the second point is that we need to resolve the irritating request for re-enter clinical data again and again for different applications. The principle of one entry, multiple uses should be respected and enforced. So that's the 2 points why I think it's important. if you want to convince physicians to go the extra mile in recording correctly, seriously, and continuously, you need to motivate them. You can motivate them by rewards, but I think the biggest reward for the physician will be that if they do that right, they can, what I call, make use of it, internal secondary use. You can use it, if they don't record correctly, the decision support they want to use will not work correctly. They will, the clinical pathway will not work. They will not be able to help use a sophisticated guideline platform or make use of independent knowledge databases to ensure safe and effective healthcare. And I think this could potentially be a really strong driver for semantic operability. And these are the 3 points I wanted to make.
Thank you very much. Petra, can you inform us a little bit more from the patient perspective?
Thank you very much, really. And I won't abuse the fact that I've already had the chance to speak, and I'll try not to repeat myself from earlier on. I think from a patient's perspective, one of the main benefits of interoperability is actually something that was just mentioned by Bob. It's the fact that we wouldn't have to give the same information over and over again. It can be very frustrating as a patient if you're asked to give the same information over and over again. But I think more important than being frustrating is it can undermine the trust in the system. If I've just seen a doctor and I then go to see a nurse practitioner and I have to give all the information again, I worry that maybe they're not talking to each other properly, that their systems don't talk to each other. And I think that, so it's annoying, but it can also undermine trust. And if we're playing alliteration, Michelle mentioned 2 words beginning with T, and I think actually trust is just so important. If we really want to advance to the next step, we need trust, and interoperability is a key to trust. I think the other thing is that good interoperability will actually simplify the patient journey because it will allow us to move more quickly through the system, and it will enable real seamless care. The big challenge, however, is extending it beyond the borders of traditional healthcare so that we can include the patient's data, so the patient can add their own data, so that schools, workplaces, ambient data from my leisure time activities, from my sports centre, perhaps data that I want to input myself about what I've eaten, so all that can come into the data flow as well. I think that's really important, and that's a really big challenge to interoperability, because there we're not talking about something that comes in conveniently codable terms, but we're talking about real language. Thank you.
Thank you very much. Last but not least, Christoph, what do insurers think of interoperability?
First of all, I will mention that the title, Health Data for Care and Research, we will be 100% agree with that, to think both together. This to think how we can improve healthcare system for the patient. We representative for 25 million insurers and patients, and our money is from the patient and insurers. It's not money from the companies himself, and we see the extraordinary power of interoperability and semantic health. Why? If you look to the healthcare system, we have a big tension between huge tension between modern technologies, devices, technological options, and of the other side, the healthcare system. And interoperability allows to become through what we like to modernize the healthcare system. And so the target, the goal is what Mary Baker also mentioned, to have a preventive system, a personalized system, a predictive system, a personalized center system, and also a participative system, that the patient plays also a more important role. And this is really a bottleneck to come forward to a modern system.
Thank you very much. Thanks to all. You already covered a lot of ground around interoperability, why it is important, but I'd still like to ask you, are there more aspects to this? Would any of you like to add a little bit more about what are the real healthcare needs that make us continuously work and strive for interoperability, advancement? What are the concrete challenges that we still need to address?
Thank you, Mary. We all speak about coordination of care, chronic diseases, rare diseases, but also patients with multi-pathology and multi-polymedication, as it was said already. We all spoke about the fact that the resources are rare. So in this case, we need to optimize, and how to optimize when there is so many people that need to be cared. And for that, we also need to adapt and to predict and to prevent, and it was very well said in the sessions before. But I mean, for the patient, it's like, if I may make a bad analogy, like banking system. Healthcare is a little bit relate in very simple services for anyone. By the way, not only the patient, but also the citizens. And having said this, if we want to have some kind of personalized services for every and each one, by the way, we need to balance with privacy, as also mentioned. But what I would like to add on that is we have a very nice illustration of privacy this morning. But privacy is not is a must, but it's not a unique concept. By this I mean that when you are a patient, you act and you behave differently than when you are a citizen and when you are a mother or a father. And so we need to have some kind of system in order to be able to take this in a reality. I mean, I could change my behavior depending on my mood, my health, and so on. And it's very important in this case that we will be able to have some flexible type of solution and not one fit for all. And having seen this, I think that in this case we need to have some kind of thinking about who is dealing with what for the benefit of whom. It's to say that you know this in the health system particularly, it's like a triangle. The one who benefits the most is not the one who works a lot to deliver some value. And I think this is one of the big challenges that we have. And on top of that, there is a timing issue, not only the behavior depending on the mood, but we all know that regulation and legislation is maybe not the right and unique level because technology is going fast and people would not wait a little bit more. And our challenge is to be able to maintain data consistency over time. As the Macintosh this morning, you do not expect to have any floppy disks because even if you have it, you have no reader. So we need to think about this kind of potential challenge and also to try to integrate more the pieces of data and the huge data that we have. Thank you. Shane?
Thinking from a kind of national perspective, one of the dangers, challenges that we have is saying, okay, so we've identified some standards for particular message types or whatever, therefore we'll determine a date by which everyone will implement it, without having really thought through actually setting the standard is kind of a very early step in what can be a long road in terms of supporting implementation. Bob, you talked a bit about ease of use for those who are entering data, and certainly the whole issue about training and education, making sure that we're providing kind of appropriate implementation support and so on. And a lot of the discussion in the standards groups is now, I think, recognising we need to think much more about implementation guidance. And alongside that, Michelle, from what you were saying, the kind of the incentives, the levers, how do we help ensure that people are implementing and using standards, particularly when we're looking at one group recording data in order for someone else to be able to use and gain the benefit of the data. And that kind of understanding of kind of mutual reliance and so on is important in terms of encouraging take-up and use.
Maybe it's also interesting to point at another crucial issue for semantic operability, which would be unexpected, as the communication between patient and physician, especially communicating as a physician with patients who speak another language, and even if they speak physician and patients are from the same mother tongue, their language is at a different level. There is the technical and the lay language comprehensiveness, the ability for patients to look into the EHR and understand what's written there. Semantic interoperability, support by terminologies, can do a lot to enhance misunderstanding, not only for cross-border care, but also for dealing in our country with the migrants, which are now in many European countries more than 10% of the population. Recent migration and not yet adopted or not yet fully mastering the thing. So communicating, overcoming the problems of multilinguality and overcoming the problem of communication between technical people and lay persons, semantic operability can be very important to bridge that too.
I'll just say one more very quick thing, which is I think that the biggest challenge for interoperability still is critical mass. We haven't got enough people who are demanding interoperability. We all demanded interoperability eventually between different types of operating system and computers. Many people in the audience have Apples. They like them, they're very wedded to them, but they occasionally want to communicate with people like me who don't have one. We'll overcome that because as consumers we've demanded that happens. We don't demand in healthcare in the same way, and until we get that critical mass of demand, I don't think interoperability will go to the next step.
So Michelle mentioned that we lose money. That's true. We'll lose 15% of our budget for inefficacy in the healthcare system. But the bigger problem is we lose the benefit for the patient. And it's so important to have the right information on the right place to the right person in the right moment. And if you have personalized medicine, but not the right information, not the personal talk to the patient, it have no value. So it's necessary to bring this together. And I think I do agree with Petra. In certain areas we have success, but not in the broad range. And we have different situations in different countries. So Germany have other situations, perhaps as the United Kingdom. And every country has their own innovation cycle, but we have also to harmonize this.
Thank you very much. Then now with more informed view of the challenges that still remain, can you tell me what do you think of the maturity level of large but also local ICT developments, deployments primarily, and large-scale implementations? Because a lot has been invested, big investments were out there. How do you see the state of the art?
There is a different way to understand the question. I mean, either we could try to explain how good or not good we are in a country level, or we could try to think about what happened when there is health ICT deployment. I would say it's the starting point of the journey, because when we are there, we need to see if there is a common understanding of what is deployed, if we share the same concept, the same functionality, if we agreed on the rules in order to use this, and finally, who uses it? Is it adopted on daily routine or not? And how to try to reconcile the different point of view of the people who are really pleased to see there is something to use, but for their own position, mission, like if I could be short, how to reconcile the regulatory point of view, the clinical one, the safety one, the patient one, and so on. Having somebody who takes care of what the horizontal characteristic and principle that anyone wish, but no one wants to pay for and to maintain over time. So it's quite difficult, and it's probably on that we have to focus. And if I may be a little bit aside of the political correct way, I would say that interoperability is very nice. In the real world, it's not yet there. But if we try to communicate, even not totally in the ideal world, with the 4-layer that we all know regarding the European interoperability framework, it will be better than waiting for a wonderful ideal tool. So, but I'm sure that Jeremy don't share my views, so I'll give you the microphone.
It would be nice to have a panel where we're all arguing furiously and make it more kind of lively, but I think I won't be arguing with anything Michelle has said, but perhaps a slightly different take on it. One of the things which we've kept asking ourselves, certainly in England, in terms of ICT kind of deployment is, what does success look like? How do you measure it? How do you know when you've got there? And we spent a number of years kind of measuring what we might term inputs, numbers of connections, numbers of transactions, and so on, then starting to try and identify how you can measure some outputs, and realising increasingly over the years that actually what we really want is outcomes. We want to see kind of a real difference, and I think if that was a scale on which we were trying to measure maturity, then we've still got a long way to go. But on the other hand, I think, was it Deepak this morning who talked about the kind of the learning health system? It is a cycle, and whatever we implement, that in turn will bring new challenges, new possibilities, and new opportunities. I think a lot of what we have done so far has looked at recording care that is provided. I think what Mary was talking about earlier in terms of the preventative health agenda is something we haven't really scratched the surface of yet. We're just kind of gathering some of the idea of some of the data that we've got, but how can we use that and so on. So whilst I may not give a particularly high score for level of maturity, I think in terms of optimism about seeing how things can move forward and develop, I think lots of opportunity in the future.
With regard to maturity, we still see today that in hospital systems and also in many primary care systems, the EHR systems are proprietary and often not standardized. We have 3 similar standards, OpenEHR, HL7, and 3606, which could be made interoperable, but the problem is that many of the proprietary solutions don't align with any of these 3. So, and locking the users in a proprietary system, but also limiting their choice of, for instance, knowledge providers for decision support. Another point about maturity is how good are you talked about training physicians in order to do correct coding and correct data entry, but training is in one point of time. There also need to be a help every day, every moment that you help. How sophisticated is the support for clinicians who have to enter today? Or how sophisticated is that support system? Does it use natural language processing? Does it use semantic web techniques to overcome the hurdles and to help us, which is not easy, that the human interface with reference terminologies, which are machine concepts, how can we express the language that we use every day and bridge it over to these reference terminologies with everyday, day-to-day sophisticated support at the point of care every moment that we do a data entry. And I think there the maturity is pretty low. We will, in a global healthcare system that marries primary care and healthcare system and hospital care, we will need one overarching granular reference terminology. But we need to marry that wish, which is a public health wish, with the wish of clinicians for their own classification system that is proper to their specialization. It's also primary care or any other specialization. We all have our own classification systems that we need to, and we want to make a combined use of this granular overacting terminology on the one hand, and a classification system of our domain. And make that happen is also a very important challenge.
Thank you. To try and add a slightly different perspective on things, I think from a patient perspective that we have a lot of solutions in healthcare, a lot of IT solutions in healthcare, but one of our biggest problems is that as a community we're not very diverse, and whether, even if we look around this community, a lot of us know each other, a lot of us have worked together before. We're not very good at learning from other sectors, but we should do. We should look really carefully at other sectors that have done well in adapting to the change of ICT. We should look at what Uber has done to taxis. We should look at what Spotify has done to the music industry. We should look at what Amazon has done to retail and learn from them. And sometimes we do that. You may be aware that there was a very interesting one in the UK when Great Ormond Street Hospital, which is a children's hospital, decided to work with the Ferrari pit stop team in understanding how a time-critical, safety-critical industry does things differently. Now, at first look, you would say a pit stop and an emergency room for a children's hospital, what can they learn from each other? But of course they could learn a great deal. But also in other sectors, Nike recently developed a new shoe, as they frequently do, so that we buy yet another one. And they work together with people from the power tool sector. Why power tools? If you use a power tool, shock absorption is a key issue. So they said, okay, let's look at other people who work in shock absorption and see what we can learn from them. And I would say that's actually where we're immature. We haven't got the confidence yet to say, let's learn from other people. And that's what I would say is the biggest challenge in terms of maturity for this sector.
Okay. So in Germany, you have on the level of hospitals, excellent software. For pharmacy, we have excellent software. We have for lab, excellent software. For office-based physician too, but there's no connectivity, there's no patient orientation. So on this level, really poorly. And this is really the challenge for the German healthcare system. And you will see the take-off in the next 3-5 years in Germany. And then the starting point will be perhaps a medical prescription. So there will be investment in this sector. But we have a lose a long time. So this is also a problem. We are not quick enough.
Thank you very much. There are still limitations of ICT, I hear from you. Can you elaborate a little bit further? Would you like to give us some more examples on that?
Yes and no, I would say, because to me, the limitation of ICT are exactly the same one that the advantages of ICT. Computer is the master of ceremony of terrorism, and what you get is what you put in. So it could be nice if you want to have a strict process that you are sure that it's the right one. But it's also very difficult if you have unexpected events and you are not able to put in a system. So agility is good for the code, but maybe less evident to put in when it goes to unexpected event for patients. So really we could retrieve only what we put in, and what we put, whatever the people are clever, it's only modelization or representation of the real world and not the real world. So don't forget about that. I think that computer and ICT is about machine and we're human, and there is already some illustration this morning about the difference and the difficulty to understand each other. It's not only different culture of human, but also to be able to be understood together.
Thank you. I think at one level, rather than using the word limitations about ICT, I'd probably talk in terms of it's an opportunity that hasn't yet been tapped. But I think limitation applied to, for instance, how a national organisation would be wanting to plan to deploy services. One of our issues in England is how we make this relevant. There's a danger, I think, that we can kind of start with a solution. Oh, we've got a network, we've got a system, we've got this, or whatever. Therefore, we'll roll out this system without thinking in terms of, so what health benefit are we seeking to address? And I think part of the issue for us at the moment is, if we're trying to make records available, encourage teams to work together and so on, how can we describe this in the context of national targets around improving mental health services, for instance, and target that sort of area in terms of how can we help those who are involved in supporting such services and demonstrating the benefits as such. So I'm just worried that sometimes we look like solutions in search of problems without really understanding what it is that we're aiming to do and the benefits that we're seeking to achieve.
One area that for improvement is probably catching the context of the information and the ability of ICT systems to capture continuity of care and the journey of the patient across a process or even his lifelong journey. We are pretty good in structuring the information in the EHR from a static way, but marrying it with business processes, with care pathways, is still in its infancy. And I think there's a new standard coming out on continuity of care, and I think it's a big challenge and an opportunity to overcome a limitation of the current systems to address this need for continuity of care along the lifeline of the patient, and that this is a major challenge and opportunity to improve.
Thank you. The limitations and the challenges that still exist for ICT. I'm not an expert on the technology side, so let me point to two other challenges that I still think we need to overcome. One is we have had big investments in ICT in healthcare, but we haven't actually managed to prove conclusively or even satisfactorily the return on those investments. And I think the reason for that is that we're using a pharmaceutical-dominated, random-controlled trial model of proving ROI for something that doesn't lend itself very well to that. So I'd say the number one challenge for me at the moment falls in the hands of the economists and statisticians, perhaps. Let's find a better way of finding the ROI so that we can continue to make the big investments. And the other one, I'd go back to Niklas's presentation of this morning. Governance and the legal system is absolutely core to building the trust to take it forward. But again, there we have perhaps an old-fashioned notion of what that should be, and we try to come up with rigid rules, and they don't fit, or we come up with very, very wide rules, where the answer is, as Niklas put it this morning, it depends. Neither a very rigid rule nor an it depends rule is going to help us here, so we need to think about new ways of building governance structures as well. So I would say those are the big challenges outside technology that still face us.
In Germany, we have a lot of actors in the healthcare system, and these actors have also different heterogeneous interests. And this makes it difficult to make it quick and easy to modernize the system and to use interoperability. Everybody has their own system, and we have to look how can fit it together. And if you look a little bit deeper, then you see you make a platform for cardiologists and for diabetologists to work together. But in reality, they don't work together. But we have created a platform to work together. So it's not so easy, because every physician sometimes thinks this is my patient and I'm the expert. So the understanding of cooperation, coordination and communication could be better. And this is also a process in the Scrum healthcare system, and it's also a little bit also generation. I think if you look for the new generation of physicians in Germany, you have other thinking. So they look more for work-life balance. You have a high amount of female physicians. So this will be more open now for changing. So it could be easier for us to modernize the system and to make it a more innovation-friendly system. This is in the sense of the patient, the benefit. Innovation means benefit for the patient. And so this is our target, but it needs a little bit of time.
Thank you very much for the several positive messages so far. May I ask you to only briefly reflect on standards adoption? And I say briefly because I know we are all passionate about the need for standards adoption and how we can support this. So that's why, in the interest of time, please. Very good.
Okay, well, that was a brief input from Michelle. I've said a bit about standards earlier in terms of adoption goes way beyond the kind of approval or acceptance of the standard, that the implementation is hugely important in terms of training, and Bob was right to indicate kind of ongoing support. And I think just alongside that, again, in terms of the life cycle, the kind of the learning health system, the fact that always there will be new standards that we need to develop, there'll be new things. And at the moment, kind of standards for outcomes, for instance, will be one that we'd be thinking of. So don't think, oh, well, we will have solved all of this in 1 year or 2 years' time. There will always be new things, and it will be a continual upward path.
Well, too much energy maybe is wasted in redefining over and over information models and clinical models by different standard bodies, by different vendors, by different countries, and often without the input of clinicians and patients. So, if we make standards, we should include the input of clinicians and patients, and we should try to avoid duplicating efforts and find what is common in the competing standards. I was surprised to see that standard bodies who produce very well elaborated standards, who even took many years to produce, that it's once they are there, it's so difficult even for vendors, small companies, to access these standards, and they come at a hefty price if you want to read it. And sometimes it's no surprise that in small startup companies producing mobile health have a financial burden in accessing all these standards. And I think something should be done on the business model of dissemination of these standards, because that is a hurdle. So that's what the points I want to make.
I'll pass to you.
Okay, thanks. So, who remembers the story of Microsoft and Apple? The success of Microsoft was only they give an answer to the need of standardization. This was not perhaps a better product. So standardization is really necessary and a prerequisite for example, for interoperability. And it's necessary for multi-stakeholder, because we have multi-stakeholder in the healthcare system, and we need this standardization. And my experience in standardization, I was into some working groups. It's not so easy sometimes. And what we have to think about that this process needs also time, and but you have also to see that on one hand you have developed standard inside the healthcare system, and you have dramatically development outside coming into the healthcare system. And the strategy must be, and that's also what we discussed in Germany, bring both together. The new developments, viable, whatever, devices, and what we have in the healthcare system. So we need an open system for that. Then we can use the energy to come forward in the system.
Thank you very much. We are about to finish with the final round of questions, which I will group. And please answer whatever you think is most important to answer for the sake of the coffee break. Thanks for this. I would like to ask you who are the key actors that can help us scaling up interoperability, and how, and what are their respective roles of all these actors to improving standards adoption?
Thank you, Lenny. Who are the actors? They are all over the audience there. We have a lot already this morning on that. What I'd like to emphasize is more that we spoke about data, how to reuse data, how to store data, how to have good principle around the data, and add before some elements regarding metadata and the condition of this data plus metadata to be over time, and the difference of behavior. But I would like to say that most importantly, as it was touched also by Christoph before, what is important is co-design, co-construction. Not to wait that we have the data in a silo or in a very nice open shop to do something, but try first to understand what for we are there, and not in silo, is to say, not the industry pharma, not the clinical research, not the health professional, not the patient, but all this community together to co-construct in order to be able to deploy in the life cycle advocated by Jeremy before. And for that, I think that we maybe don't touch enough the way by which the governance could happen. We had in a previous project named Calliope tried to work top down and bottom up and make a lot of interaction between people in order to build the model together, but not only once, but really to be able to tackle a little bit the real world. And for that, we have to break some kind of glass ceiling between public and private, big and small institution or whatever, and to be able to work together to what we called badly, I would say, use cases, to have some kind of business model we agree upon. But having this, saying this, I think that in the role of the public authorities, because we are more or less supposed to have this role, I think that first we have to try to stop doing things, to try to observe, to try to help, and it is to say to be responsible for all the things that people don't want to do but would like to have. And it's not so easy. Because everyone is doing his best, it's a willingness, but honesty is a human factor, if I could say so. And that trust and credibility are to be built upon over time, and the people who are supposed to be responsible for these rules are always the bad guys. So try to help is better than saying, oh, everything is fine, this is a new idea, this is a good project, and please go on. And the role of the public authority is also sometimes to say, we don't know, please, this initiative was good, but it has to stop, and to also be a garant of the engagement for the patient about this type of things that we hate to speak like I speak so far. Sorry for that.
I think I'll hand straight across to Bob, actually.
Well, I think we should acknowledge that in this issue the real decision makers are in the public health authorities, the health insurers, so-called payers, and the health industry. The physicians and the patients are not very powerful in these discussions. We can hope that the decision makers of these three constituencies collaborate, at least, to develop a common strategy for promoting standard-based ICT solutions, and in doing so, that they listen to the beneficiaries, the patients, and the physicians. If I look within the communities of the medical specialties, primary care, but also the different medical specialties, pneumologists, oncologists, the number of actors that is interested in these dry matters of standards and semantic operability is limited. And among the physicians, there are only a few white elephants who are willing and able to drive these processes. Those who are willing to take responsibility should be supported, trained, and coached. And as an advice, I would say that most likely it's best to target the officers, the scientific officers of European scientific associations, those guys who are now responsible for the development of guidelines, of cross-national research, of decision support systems, and of registries in their fields. These are the guys we need to get on board to cooperate in this discussion. And I think research officers of the European, but also of the national scientific medical associations should receive the means to participate in the development and implementation of ICT solutions backed by standard adoption and to promote secondary use of clinical data.
So, conscious that there's only me and Christophe standing between you and coffee, I'm just going to say something slightly flippant, but I hope that has an element of sensibleness in it. What's the biggest driver of anything that we do, of any choices that we make? It's desire. It's what's in it for me. And we haven't cracked that nut in standard. And I would say, flippantly, one of the reasons why is in the language. Standard, the word itself, is boring. Nobody chooses standard. People choose bigger, better, higher, longer, taller, whatever. Nobody chooses standard. Standard in marketing language is a euphemism for second class. We have standard class on the airline. We all know what that means. So I think actually, if we want to harness the desire of everyone to get behind this, we need to find another word other than standard.
Language is relevant because it has the chance that you can understand each other. And for standardization, you need also a legal base. This is also necessary, and everybody is welcome which support and help to solve this problem. That's also clear, and I think in such area, Robert mentioned it, it's more difficult, and we have to find a solution for this area too. But in principle, we like to work together with startups because they are keen. They think really ahead, what you say, desire.
Okay, thank you all very much. There is a last chance for just final, really brief comment, which is not a must, only if you would like to add something on how can decision makers do more? Because I take it for granted from your passionate statements that you are all convinced you will do more, bigger, whatever. Not to mention interoperability standards anymore. If you would like to make a really final statement, please go ahead.
Last word, always difficult. I think that we have to be as transparent as we would like the other to be, to use as much as possible the so-called, but not only for calling it, subsidiarity principle. And finally, I would say that it could be nice if we could just ask the question, what will happen if I change position? If I'm not in a position of public authority but the patient, and from the patient point of view, if I will be an industry provider, and from the industry provider, if I will be a health professional. And it's clear to me because in some of our smallest country, I just realized some years ago that people react differently because they know that in at least 2 or 3 years, they will change position and be the one that is opposite to them. So it helps a lot to have a more relative view of what could happen. And if we do all apply this principle, I think that we could move forward together.
I think I've detected a desire for people in terms of coffee, so I will therefore hand on to Bob again.
I'll make it brief. Well, semantic operability is probably the conditio sine qua non if we want flawless communication between settings of healthcare, primary care and hospitals, countries, from care to research, from knowledge databases to clinical care, even from physician to patient, or healthcare provider to patient, and this in multilingual Europe. So, if we don't have semantic operability, it will be difficult to achieve all that.
I'm going to actually have my last statement by asking you to do something. When you go for coffee, talk to somebody you haven't ever talked to before and see what you can learn from them. Open yourself up to something new.
I do agree with Robert, and I think for everybody's self and also for my company, we have also something to improve.
Let us thank all the panelists for a really insightful panel discussion.